Well, good afternoon. I'm Dr. Robin Leight. I am an obstetrician gynecologist on staff here. Actually, our office is called Rutland Women's Healthcare, but we are on staff for Rutland Regional Medical Center. And I've spoken on menopause a few times now, but try to give something new to it each time. So welcome. And at least I'm only competing with 40-some degrees. I think if we had 50s or 60s, you would have dropped out. It would have won because warm weather had come to Vermont. So hopefully by the end of tonight, I'm going to help you figure out for you, is it a milestone or a menace or both? So here are my objectives. Why and when does it occur? What is menopause? What is perimenopause? Who needs treatment? What are the treatments? And I thought I'd throw in, do men have a change of life? So my mother is 30 years older than me, and I only found out making this presentation that she menopaused at 43. I thought she menopaused when I was away at college. So, just a little background of where I trained. My bachelor's is psychology, Temple University is in Philadelphia, for those of you who don't know. And I went on and did my medical school training, also at Temple University, Philadelphia. And then I did my OBGYN residency in Reading, Pennsylvania, moved up to beautiful Vermont in 1992 after doing a vacation or two up here and getting a feel for the state. And then I had my two children in 1993 and 1995. So when I got here in 1992, of course I had education about menopause. Not a lot of menopausal patients. You mostly train as providing care in clinics. You get a lot of obstetrical, and you get to learn a lot about surgery and assist surgery that the doctors training you are going to do upon their patients. But we didn't really have a menopause clinic, so it wasn't really a whole lot of experience. So that's going to represent about how much experience I really had, and to be honest, about how much interest I had in menopause. So why do we menopause? It's the end of our reproductive years. Our ovaries kind of shut down on us. It's really kind of a whole cascade going on, but the bottom line is if the ovaries can't function anymore, then we're not going to release eggs anymore. We're also going to have a change of our hormones that were making us capable of releasing that egg and being ready for a fertilized egg to implant. And this process is actually going on kind of gradually for us, but then it really kind of picks up speed the last 2 years before our last period. And there's still not really excellent evidence of just why it happens and why it happens when it happens for each one of us. This grandmother theory is that in the human species, maybe somehow it was realized that grandmothers had a pretty wonderful role in helping with the child rearing. So the women needed to transition into being grandmothers rather than mothers any longer so they could fulfill that. So that was just kind of interesting. So when does it occur? It's just a little bit of where the word even comes from the Greek. And the peri means enclosing, so that's going to be the period sort of leading up or around your menopause. So we define menopause as the period of time that includes your very last menstrual flow and the 12 months that follow. So it's really like we actually make the diagnosis by looking back, when you can tell your doctor, my last period was 12 months ago or longer. And perimenopause, which is really thought of the transition to getting to that point, That idea became pretty popular in the 1990s to think about being what perimenopause meant. The average age is 51.3, 51.4, somewhere right around age 51. And there are some things that can influence. There can be similarities between mothers and daughters. Come back to that about my mother and me. It can come earlier, the more irregular the woman has her. I might not be giving you the association, I'm not sure we know the association, but women with a lot of irregularity in their early 40s may be heading there earlier. Tobacco use, strict vegetarians, low body weight, living in high altitudes, and under surgery, of course, well, I want it to make sense that if your ovaries are both surgically removed, then of course your ovarian function is gone. But I'm also including surgery that just does partial removal of your ovaries or one ovary. And even a hysterectomy, which all I mean right here by hysterectomy is the removal of the uterus, can bring on menopause earlier, even if the ovaries are left in place. So what might make your menopause come later? Excessive alcohol use and the greater number of pregnancies. And it still seems to this point that it does not seem to be related to what age you started, your race, or your height. So let me tell you a little bit about premature menopause. That's if you menopause before age 40. It's only going to happen in about 1% of women who get to age 40, and an even smaller fraction if we look at how many do it by age 35. Of course, the most obvious reason would be the surgical complete removal of both ovaries, whether it's at the one time or over time, a couple different surgeries. 46XO is a female, and she is a Turner syndrome, and she could be sitting in this room right now, and hardly anybody would know that she was a Turner syndrome. But because she lacks a second X chromosome, she is not reproductively capable, and she will definitely have premature menopause. So those patients, when we can recognize them earlier, we're going to keep a closer tab on them. I'll talk a little bit later about some of the risks of losing our estrogen, and we would really worry about that in a Turner syndrome female. If we have certain autoimmune disorders, and if we've undergone chemo or radiation therapy for certain cancers, that might only be a temporary menopause that we'll go into. This is also called premature ovarian failure, and as I just said, it's not always permanent, and there are women who do appear, for all purposes, to be in premature menopause, and yet they're still ovulating and still can get pregnant, and we all witness that, gynecologists in our careers. So when do women hit perimenopause? Well, on average, it's mostly thought to be the 4 years leading up to their last cycle. But here's some averages for you here in the United States, around age 46. 95% of women will occur right in that range there, 39 to 51. I just said 4. Another source on this slide says 5 years. And maybe this perimenopause actually can go as long as 8 years. But it could be pretty short too. Some women I don't think even notice their perimenopause. So is there another stage to menopause? Well, yeah, we talk about women being postmenopausal. So that's that remainder of our lives, or that last life stage when a woman is done all of her menses, done her reproductive capability. The symptoms that she might feel in perimenopause and menopause will definitely ease and go away. They will. But the loss of estrogen has some long-term impacts. So let's talk about what does happen in perimenopause and menopause. Again, back to those failing ovaries. which is going to impact our hormones. Perimenopause is more of a fluctuation of the hormones rather than a dead dropping off or rising of another hormone. But then when we actually are in our menopause or a little further along in our postmenopause, all of the hormones have kind of reached their new steady state. And our estradiol, which is our primary estrogen of our life, we actually have 3 estrogens, but the primary one in our reproductive years is estradiol, is going to become very low. Progesterone, which we don't really measure very much, especially not for menopause, but that's going to become very low. And the FSH, or follicle stimulating hormone, which in our reproductive years has a cyclical pattern it goes through to help our ovarian function work for us monthly, that actually ends up revving itself up high because it sort of keeps trying to send its signal, but it's not working. As I said before, the perimenopause, which is also called the menopause transition or the climacteric, is 4 or 5 years before the final period. So what's unique about the perimenopause versus menopause is what happens to our menstrual cycles. Again, not every woman is going to notice a significant change, but in general, on average, the length between the start of each of our cycles will probably lengthen to be more like 40 to 50 days apart. Normal is about 25 to 30, 35. We might skip some of our cycles. Amenorrhea is a complete lack, but when I'm using it that way rather than saying menopause, I'm just talking about shorter periods than 12 months of lacking our cycles. An anovulatory cycle, so we did not ovulate or release an egg, so some of our hormones are still doing what they were meant to do, but the balancing hormones that came out of ovulation aren't there. So sometimes those are even thought to be much heavier and worse cycles when they actually don't follow an ovulation. And our hormones are going to fluctuate, leading to hot flashes, trouble with sleep, changes perhaps in our mood, and vaginal dryness. We're also going to get some negative, not so good impact on our lipids and on our bone density. So those are a couple of our worries about what happens when we're losing some of our good natural hormones. So we're moving along. My career is moving along, not just tonight, but since the 1992 when I got here. So I do care a little bit more about menopause. I might even be thinking about my own menopause. So let's go through menopause symptoms. And I just said that the thing that was unique about perimenopause is the menstrual changes. These symptoms we're going to go over now certainly can start in the perimenopause and then continue into the menopause, or maybe just start at the menopause. So what is a hot flash, or sometimes called a hot flush? It is a sudden, pretty intense feeling of heat. It usually hits the upper body, could include the chest, the neck, the face. We might even turn red with a hot flash or a flush. They usually only last a couple of minutes. Of all the women who do report getting hot flashes, almost 90% say they're going to feel them daily, and about 1/3 are going to report having 10 or more a day. Besides that intense heat, I've also put up for you some of the other feelings that come from it. You actually can sweat, then you might chill, you might feel anxious, you might feel palpitations, you might feel clammy. Any or all of those. So how long are these hot flashes going to last? When I first made this slide for an earlier talk, I got that 6 month to 2 year out of some literature. But looking at some updates, we now know that there really are women having them for up to 10 years. And there are about 9% of women who are still feeling them into age 70. But they do go away. So there was a study of American women, and they just looked at a couple different groups to see what they could find out. So Asian American women have the least amount of hot flashes. African American women have the most. Other things that seem to contribute to the severity, the quantity of experiencing your hot flashes are some of these other factors. Being overweight to the level called obesity, having depression or anxiety, being of low socioeconomic status, being a smoker. Hot flashes are definitely more common at night, and when you are conscious of them and maybe do even get that little perspiration, that's how they got their lovely name of night sweats. So what are the sleep disturbances? So just not getting a good night's sleep, waking up once, twice, not being able to fall back to sleep, feeling very unrested the next day or over time as this keeps happening. So this is not reported quite nearly as much as hot flashes are, but still seems to hit a significant number of menopausing women. But contributing at this time in a woman's life also to her sleep is whether or not she has sleep apnea. So it's kind of confounded to know for sure whether her poor sleep is her menopause or not, or more than one factor. Those darn old restless legs that I have a lot of my patients telling me about. And unfortunately, here's anxiety and depression again, which we already know can disturb sleep. So what about the vaginal symptoms? So hot flashes and vaginal symptoms are the two most common reported symptoms, and they have the most direct link to low estrogen production. So what happens in the vagina is that the walls become thin. There are feelings of dryness or itchy or burning or raw. Even if they don't tear and bleed, it feels like the tissues could. That, of course, could make sex painful. Before menopause, it's not reported too much, and again, the research said that maybe it's in about 50% after menopause. It really is going to pretty much happen to everybody. I think it's just the different perception of each woman and whether or not she notices it because of sexual activity or not, and whether or not she's trying some lubricants. These symptoms will progress. They don't sort of just get to one state and hold steady. It's an area that really, really needed estrogen, and I don't think I put a slide in about the bladder, but our bladder also likes estrogen. So it's not a cure-all of bladder troubles, but there is definitely a boost to the bladder holding a little better, how long you can hold, how much you can hold. So there's benefit there if we were using estrogen for the vagina and bladder. Here's some of the physical changes the woman's likely to notice. Less pubic hair, tightening, closing down of our vaginal opening, the fragileness of the tissues. Our main sexual organ, our clitoris, is going to shrink or get covered over by the tissues around it shrinking. And the labial, or your lips, are also going to become smaller and just sort of blend in. So they're smaller, shrinking, and not very prominent anymore. And there is some fat, and that fat's going to go away. So we're noticing that we're less moist. Our vaginas like to be acidic, but with the lack of estrogen, they go more towards alkaline. And when it goes more towards alkaline, that's a setup for infections of the vagina or the urinary tract. So back to this all causing painful sex, continued regular sexual activity, and maybe at least finding a good over-the-counter lubricant definitely can be very beneficial, and I think is often beneficial enough for some women. I think that's why the slide before said 50% say they're really troubled by it rather than everybody, or a higher number. So do other things change? Well, it's not really that clear that we're going to have problems with our memory, but it does seem to at least be a temporary thing to have some trouble with memory, concentration. Again, unfortunately, if we're already working our way through life with some anxiety and depression, that's going to not help us here again at that menopause time. And joint pain certainly does not have to happen just because we get to our menopause. We are aging. Arthritis is coming along. Maybe if we had sports or repetitive activities in the past, even if we're not anymore, our joints are going to remind us as we age. But there definitely is benefit using some postmenopausal hormone therapy to joint aches and pains. Couple other areas, breast pain and tenderness, we can see those kind of fluctuations, but that should improve when we actually hit menopause. There are migraines that seem to occur very cyclic, right about the time we're getting each of our menstrual cycles. They should improve with menopause, but they can actually go into a little burst or flare close to menopause. And then here's some of those long-term worries. Our own natural estrogen deficiency is going to help promote osteoporosis, cardiovascular disease. Women are sort of relatively cardiovascular protected, and we have lower cardiovascular disease than men until we hit our menopause. Then we catch up with them very quickly. Skin, hair changes, again, not so clear, but some thoughts about dementia, arthritis, whether or not we have good balance anymore. Weight gain does not occur just because you hit menopause. Our metabolic rate is sort of our engine. How are we doing? What are we doing with the fuel we take in? How are we using it for our body, our muscles, our bones, our functions? And how are we keeping it all balanced? So well before menopause, our metabolic rates are slowing down. And there's not even a significant boost to that when we hit menopause. I know a lot of women seem to think it was their menopause, but I think it really was just somewhere they were heading, and somehow it caught their attention a little more when the menopause came. Back to, before I even get to treatments, we've actually can see women do better with weight control using postmenopausal hormone therapy. So let's talk about treatments. So we could all just go dip in a cool Vermont stream, and that would be any time of year in Vermont. They never warm up. This is Chaffee Falls, one of my favorite hiking trails in Pittsford. So we have to talk about hormones. So systemic refers to taking in hormones to affect the whole system. And systemic hormones consist of estrogens and or estrogen combined with progesterone or progestin, just another way of talking about progesterones. And this is by far the most effective treatment of those vasomotor symptoms and of vaginal dryness. You can use these systemic hormones orally or through the skin. That's what the transdermal is. Patches have been around for quite a while, and new products are still being developed and improved upon. So there are gels, there are creams, but probably the two biggies are oral pills and the patch. They now fall in about 3 categories of dosing: a standard dose, a low dose, and now even ultra low dose. Really, so far, the benefit is from the standard and the low dose, but that doesn't mean there isn't a role for ultra low dose in some women. So, that's the relatively newer products are going the ultra low dose. So, I kept talking about estrogen, so why am I also talking about progesterones? Because especially at and after menopause, if the women who still have their uteruses intact, they're done having their periods, or close to, if they're coming to me about this in their perimenopause or less than 12 months after the last period. Anyhow, they still have their uterus, and if they only take an estrogen therapy alone, that actually is very stimulating to their inner lining, and it's not that they will grow a cancer or a precancer, but they could. So it was figured out quite a while ago that if you balanced the estrogen, which you're taking for the benefit of improving the symptoms, with the progesterone, you could really, really, really minimize or almost eliminate that risk of a cancer or precancer inside the uterus. Almost all of the oral progesterones, which by the way were developed for birth control. So almost all of the progesterones we have are borrowed from birth control. Now the estrogen, you might say, sort of is too, but it's not. They did develop their own little estrogen products for menopause. They didn't borrow the ones in birth control, but that's where the progesterones came from. And unfortunately, they can lower HDL, which is our good cholesterol. That's our one good lipid cholesterol. So the progesterones might do that. There is this oral micronized progesterone. So there's one oral one that does not seem to have that impact on HDL. One company makes it, and I think it's still on patent. There is not a generic yet. Levonorgestrel, IUS stands for intrauterine system, is a contraception, but it can be used, and it is being used as a way to balance estrogen for women who are symptomatic enough and are going to go in therapy. So that could be their source of progesterone, and it doesn't seem to have those negative impacts either. It happens to be, there's a 3 and a 5 year lasting one, put in at an office appointment, intrauterine system, intrauterine device, and then you can take your estrogen in whichever way you decide. And then the vaginal progestins, I don't think we have any in the United States right now. So I'm going to move on to some other types of treatment. So there's a class of serum estrogen receptor modulators. They're all FDA approved. The first two, raloxifene and tamoxifen, do not help menopausal symptoms, and in fact, they can cause some hot flashes. Both of those drugs are very, tamoxifen in particular is breast cancer treatment and prevention, and raloxifene has also shown some breast cancer prevention. I'm just telling you that they're in this category. So the third one, Osphena is FDA approved to help vaginal atrophy. It does not have any negative impact on that endometrium. It can cause hot flashes, a vaginal discharge, some spasms, and some sweating, but it is definitely going to reduce the pain of sex. So what are our risks of the hormone therapies? Well, hormone therapy was chugging along pretty good. I think it was close to one of the top prescribed pharmaceuticals till a wonderful, sort of wonderful, large study called the Women's Health Initiative put out some of its information in 2002 that there was an increase of cardiovascular risk and an increase of breast cancer. Now, the purpose of the Women's Health Initiative was to prove that hormones decreased cardiovascular risk. It really wasn't put in place to truly primarily test about breast cancer, but cardiovascular risk. So part of the problem is, though, that they included women from 50 to 77, and menopause is 51. So I already told you we're all kind of cardiovascular protected until we hit our menopause. So they included a range of women that were going to have increased cardiovascular risk anyway. They mostly found the risk of a heart attack and stroke. They had women taking estrogen alone because it was appropriate for them to take estrogen alone. They did not have their uteruses, and women taking estrogen and progesterone. And that arm stopped early because of the increased heart attacks and strokes. They also found a bump in breast cancer in that arm as well, the estrogen and progesterone. But there were benefits that came out of the study: less osteoporosis fractures and less colon cancer. But an alert was raised, and the prescribing of postmenopause hormone therapies did not end, but it dropped. So there have been some further looks at the Women's Health Initiative study, and what I've done on this slide is borrowed when they looked at just the women in their 6th decade, what were the risks that they went through. So this was 5 years of use. Wherever I give two numbers, the first one is the estrogen and the progesterone group, and the second one is the estrogen only. So actually, coronary heart disease was decreased, but not significantly so much, that 0.9 in the combined, which again was the one they were really kind of worried about when they had that whole long range of women's ages. Mortality was reduced. Fractures, I already said, yep, they were reduced. Type 2 diabetes occurred less. And colorectal cancer was seen to occur less. Breaking it down into, but pretty much the same percentage for both hip and vertebral fractures, and the reduction of the colorectal cancer. So almost 98% of women either, and it happened to be conjugated equine estrogen and medroxyprogesterone acetate, that was the combined one, and then just the estrogen alone, really the majority had benefit. Here's just another look when they reviewed it in 2013, just for 50 to 59. There were a few additional strokes in both groups. VTE is a venous thrombotic event. That's a blood clot in a vein that can travel, can damage heart, brain, lungs, sudden death. In this case, this was not death. This was just the occurrence of having the embolism. So those were increased. breast cancer was only found to have an increase in the combined group, women on the estrogen and the progesterone. In here where I left it in, this actually came from another study, another large study called the Nurses' Health Study. And there was additional gallbladder disease in both groups. But they weren't able to just call it the 50 to 59. I don't know why not. But. So now, what other therapies are out there if those slides scared you away from estrogen or estrogen and progesterone if you have a uterus? Will testosterone work? Well, we do all have testosterone in us, and our ovaries do make some. It's not such a significant amount, and it's not such a significant drop at menopause. The problem with testosterone is all the good things it does for men, it might do to us. So we might grow hair more or in places we don't want to. It might impact our lipids in a negative fashion. It's not FDA approved for women yet. We've been waiting to see if they will come up with some FDA approved testosterone product, but it can be used in combination with estrogen and progesterone, and there are a couple different avenues where we can add some testosterone in. So what are those compounded bioidentical hormones you might be hearing about? Well, actually, I could drop the word compounded first and just say what are bioidentical hormones. So these are hormones that are synthesized, maybe they're based off of a plant source, and they are much closer to our own estradiol and our own progesterones than many or most of the products that the pharmaceutical companies have made for a long time now. So there is technically 2 FDA-approved products. They are pharmaceutically made, so they are a prescription. You just write your prescription, you go to your pharmacy, you pick it up. So there's an estrogen pill and there is a progesterone pill. There may be some more coming along, but we do have those. But back now to the compounded ones that really are sort of the ones that are getting a lot of press and talk. A compounding pharmacist is going to make that up. They usually are going to work with your primary care or your gynecologist to come up with an amount, so they can't just do it for you. So it still sort of goes through a prescription process, but there is no FDA regulation, testing, or approval. So I just want to caution women, and I'm not against these, and I do prescribe these, mostly for women who come already interested in them, rather than me putting them right out in the first place. But there's really nothing that says that these compounded ones or estradiol and the micronized progesterone, which were not the CEE and the MPA in the Women's Health Initiative, that they don't have the same risks that we found in the Women's Health Initiative. So what if we completely move away from hormones? And there is some products with benefits. The serum serotonin reuptake inhibitors and the serum serotonin norepinephrine reuptake inhibitors, big mouthful, those were developed as antidepressants, but they are very effective in reducing hot flashes in healthy women who do not have depression or anxiety. So you don't have to have the depression or anxiety, but we can help reduce the hot flashes with those products. Right now, only paroxetine, brand name Paxil, actually has FDA approval to be used for that purpose. Clonidine is an antihypertensive that's been around for a long time. That can show some success. It does not have FDA testing or approval for this purpose, but it does for hypertension. Gabapentin seems to be being used everywhere these days. It developed as an anticonvulsant, but it's being used for chronic pain, a couple other uses. So it's been tried a little bit. It's not FDA approved, and I really haven't found too much supporting that it's better than a placebo effect. What if we go to complementary medicine, alternative medicines, botanicals, natural products? Well, again, none of them are FDA tested or approved or regulated, so a little bit try at your own risk. I'm not usually worried about my patients trying them, but when people have tried to truly scientifically study them versus placebos or systemic hormone therapy, they do fall short. They usually fall about the same level of benefit as placebo. And in case some of you don't know, placebos have benefit. So give somebody a totally inactive treatment, they will feel some benefit from it. So it's not that there's no benefit, but that's called the placebo benefit. Just listed what some of the sources are. Why did we think these would work? How did we get into this? Because Asian women, this is much more a common part of their nutritional and health practices, and they have less hot flashes. So if it works for them, can it work for us? But it doesn't seem to be exactly translating that way. Just listed some other herbal medicines, and I've made suggestions of some of these for women who either can't or won't try systemic hormone therapy. Acupuncture with Chinese herbal actually has shown benefit over placebo. I don't have personal experience or personal patient feedback on that, but that's in the literature. There was a little bit of benefit, a slight decrease in hot flashes from daily vitamin E at this dose. And then what about just plain acupuncture or reflexology did not show benefit above placebo. So what could we just do? Well, we can dress in layers. And then wonderful fabrics that came from the world of running. And now, either women are finding those products or other smart marketers are developing those products in other types of clothing lines for women to wear and benefit from. Keep your thermostat lower at home. Watch your hot drinks, maybe your alcohol drinks too. Good old cool down with the washcloth if not a Vermont stream nearby. But there are also cooling neck bands, things you can do. And put a plug in for Quit That Tobacco. Just a little here about if your only focus is the vaginal dryness, if you're not suffering from your vasomotor symptoms or they're already gone and over with, but I told you the vaginal dryness is progressive and it's not really going to go away like the hot flashes will. Sure, you can try some lubricants, moisturizers. They help. Just listed a few of them. Inner Intimates is a product available on Amazon, and it was a woman who was particularly interested in trying to find a non-hormonal formula, and I do believe she did have some physician help in developing her product. And those products, it just depends whether you use them just at the time of sex or are they like a moisturizer that you need to be using regularly for the benefit. Just a little plug for cardiovascular disease, the #1 killer of women, particularly once we hit menopause. So much, much higher than breast cancer. And we're all so much more afraid of breast cancer, I think. So these statistics are probably a few years old. Almost all of us have a risk factor. Are we all doing our fitness? Is there family history? And more women will actually die from heart disease than men. And this was kind of interesting. So I got as up to date as 2012, when still barely half of women realized how important and how serious cardiovascular disease is. And back in 97, that was only 30%. And it claims more lives than the next 6 causes of death for women. So love your heart. Pay attention, learn your blood pressure, get your lipids checked, learn what they mean, learn what you can do about them. But heart attacks can occur even if we have normal lipids, so it's not just that. The number one reducer of heart disease is to have physical fitness in your life, if not every day, the equivalent of having it in your life every day for about 30 minutes. And the really good thing about that 30 minutes is you can divide it up. So it can be 3 10-minute episodes of fitness every day, and it's better than any drug you're going to take to reduce your heart disease. We're all caregivers. I'll include the men are in here because they're in here. But certainly women, we are caregivers. We think of everybody else before ourselves. Well, I want to tell you that you're just as important too. So let's try to be healthier and love our hearts. Go Red for Women campaign is one of the big drives behind awareness of cardiovascular disease, and you might all be aware of the Wear Red Day in February. Let's see what else I have. So I think menopause is a milestone. I think it's a natural phase. Hopefully we all get to it. Hopefully we all enjoy our postmenopause. We might have 40 years to live postmenopausally. That's how the statistics are going. And women outlive men. We don't have to take care of our periods anymore. We don't have to worry about getting pregnant. And you might start rethinking some new things about yourself, some new hobbies, new ideas, new explorations. So, here's where menopause is in my life now. I did not follow my mother at 43. I will not give away my age tonight. And I have not quite gotten through my 12 months, but I'm on my way. So menopause is very important to me, but it's very important to my patients too. And I've learned a lot since I've aged myself and just made it much more an important part of my training and education. I just thought I'd throw in a little bit about sex. Sex can be great, midlife, menopause, postmenopause. You don't have to lose your sex drive again because you hit menopause. There are lots of midlife things that decrease our sex drive. Stress, not sleeping, financial, maybe struggles with our partner. We still love our partners, but we're struggling. The best boost to sex is a new partner. Well, I'm not telling you all to go home and trade your partners, but you should both try to sort of become new partners or renew your partnership. Let's try to do it that way. You have to maybe think about intimacy, sexuality, and romance. For women, it's mostly up here. So we have to think it and feel it and want it and work on it. We have a very strong magnetism. So we just have to tap into it and keep using it. Didn't have to lose that at menopause. And this all comes from Dr. I think she pronounces it Christine, even though it's spelled that way, Northrup. And she's got wonderful books, and she's on public television a lot with her shows. And she's just really, I really enjoy when I get to hear her speak. She had some ideas about losing weight. Some of that ties into the handouts I had put in the back. Eat the plate. Half of the plate should now be fruits and vegetables. Only 1/4 of the plate should be a lean protein, and it does not have to be an animal protein. And 1/4 of the plate should be whole grains. And we probably should have a daily serving of a low or a fat-free dairy, or an alternative if you don't like or can't do dairy. How about you don't put the serving dishes on your table? You dish your plate out in the kitchen, and then your plate goes to the table. You'll think twice before you go up and fill that plate up again, instead of the mashed potatoes sitting right there on the table in front of you. And wouldn't it be nice to eat them up instead of putting them away? Eat slower. Talk if you've got somebody with you while you're eating. If just wait again after you've eaten that normal plate amount. Eat on a smaller plate. That works. I'm not totally into the weigh yourself every day, but maybe be aware of your weight on some regular basis. So when should you come see me or your gynecologist if it's not me? Well, we do care if you're perimenopausal and those periods get horrible, because they might not go the way I said. They might get heavier, they might get longer, they might come closer. It still might just be your perimenopause, but come and talk to us about it and we'll check things out for you. If you're pretty sure you did menopause, you went 12 months without your period, and you start bleeding again, that's called postmenopausal bleeding, and it might be a sign of something abnormal. And if your menopause symptoms are significant enough that you are bothered, they're impacting your daily life, come talk to us. And I really think more women need to learn about what's going to happen to their vaginas and be a little more proactive about that. And I try to do that in my own practice too. So what happens to men as they age? Well, they don't really menopause like women do. And guess what? They're reproductively capable almost till death. So there was another theory that we menopause so that the men can go to younger women. And we get to be those grandmothers back in the caves, taking care of the children we already bared for them, or their younger mates are bearing for them. But their testosterone might lower, so that could in fact affect their sex drive, their sperm production, their body hair, their pubic hair, their muscle and bone mass. For most men, they are continuing to produce testosterone and sperm, really probably lifelong. Their symptoms somewhat overlap the ones we talked about for women. Poor sleep, nervous, irritable. They don't like anxiety and depression words. They like nervous and irritable. Erection difficulties, memory, concentration. Maybe actually this puts a man into depression rather than any other underlying cause. Decrease their energy, and we already said the bone, muscle, and hair can change. And I guess that's it. So we do have time for questions. I'm going to take a sip of my water while you maybe think if you have any questions. I do think it's a very personal topic and, really, hopefully, a very comfortable one you will come to with your primary care provider or gynecologist. If that hasn't happened for you, work a little harder. I mean, maybe just do that as a little special aside. Doesn't have to mean you really completely change your caregivers, but you might just go seek a little help about menopause if you haven't been able to. You could also write down questions. Kathy? So I'm being asked if the woman has gone the 12 months without her menstrual flow, and now she might be at her 13th month or later and she bleeds. Why could that be happening? So yes, nobody says that we all perfectly fit in this mold, that 12 months is the absolute limit of when you can, and I think I've definitely had patients, but we have to worry that that could be a sign of the beginning of a new process. And it doesn't have to be a bad process such as a cancer growth, but the symptom of precancer cancer of the uterine lining or the cervix, if it gave off a symptom, is bleeding. So that is our number one symptom to worry us about cancers from the areas that if the tissue growth shed and came like a bleeding, it would come out of the woman's vagina. So I have to look at her vagina, her cervix, and check somehow her uterine cavity. But there are benign growths called polyps. Fibroids are a type of growth that generate from the muscular wall of the uterus, but they don't always stay just in that muscular wall. They can bulge into the inner portion of the uterine cavity and cause bleeding, either related to a menstrual cycle or not related to menstrual cycle. So those are probably the most common things. Of course, if the person's taking something and they're not thinking that something is stimulating, maybe some of these over-the-counter products, maybe. I mean, the reason those natural herbals and botanicals are even being still utilized is because they do act estrogen-like. So maybe they could stimulate some tissue. Another question? I've heard that a little bit. I've not really learned that as a pattern or come across that in any of my reading. So it's not the most common pattern. I was asked, by the way, if you missed the question, whether after the menopause has occurred and the vasomotor symptoms are still occurring, can they come cyclic? I would imagine me sort of almost like mimicking, it could be the menstrual time, but it's not. I seem to hear that a little more commonly the closer to the last period a woman is. That might not be quite what you're experiencing or heard or asking me. I don't know that it means anything more than, guess what? Maybe the moon's doing it to you. Because it has a cycle every month, but so it kind of depends on her age, but in the context of my talk tonight, and if we're thinking about a woman who's in her 40s or right around 50, then yes, that is almost, you just pretty much described what an anovulatory cycle can do. What's happening is that FSH, that's rising, is promoting estrogen production as best as it can. And if the ovary can still make some, and we can make a little bit in our adrenal glands, and we can make a little bit in our body fat too, we're pretty much still sending enough of a signal to build menstrual tissue. We're lacking where it normally balanced with what happened with ovulation and the role that happened to, once the ovary released the egg that was ovulating that month, the little left behind corpus luteum has a role in sort of balancing what's happening to that tissue buildup. And then the finish of that cycle is realizing there's not a pregnancy, and everything sort of dwindled off that was getting it ready for a pregnancy, and you shed a predictable period. So.
Can it ever come back? I mean, can you be...
So can you go through that and then go back to normal?
And then would it come back, the ovulation?
It's possible. But it probably wouldn't come back regular. Anovulation might be sporadic, might seem a little prolonged for a while. I definitely have women who will think by their symptoms they're in menopause if they don't quite equate it with the lack of periods or the 12-month lack of periods. And then they go back to quite normal. So some women go in and out of that. Yep. So there are so many, being asked what is the thought process of the use, I would imagine, of hormone contraception. You didn't quite say it this way, but I guess what I would say is, do we still believe in it? Do we use it? And is there a deadline? So we have enough research of longevity to now know that the oral combined estrogen, progesterone, hormonal contraceptive, so the good old-fashioned birth control pill that was taken in a little 4-week pack or 3-week pack, and irregardless, it was only 3 weeks of active estrogen, progesterone, and then the 4th week were these fake placebo pills. We now have enough research to show that it's safe to continue on that type of contraception up to menopause. While you're on it, you can't tell that you hit menopause because it gives its own, even if it's very light, even if you stop, it can give its own little bleeding in the placebo period. So you actually don't know, but it is okay to take it to get you through to menopause, either because you need or want it as your contraception, or you like what it did, how it improved what your own periods would be like. There are some patients we're worried about, tobacco users and women who have either a very strong family history or a personal history of those thromboembolic events. They have to go in their own category, and there are contraceptive, even hormonal ones I can offer them. I also wanted to say that what that long-term research has shown us is that the good old-fashioned estrogen, progesterone, balanced birth control decreases ovarian and uterine cancer as long as you've taken it for 5 years.
Okay, so
and is neutral to breast cancer.
Okay, so if you have not been on the pill,
so how do you get off of it? How do you get off of it?
And it's not the pill. If it's
right.
Yeah.
Right. So if you are using maybe I could say any hormonal contraceptive method. I mean, if you're using condoms, no, but if you're using condoms, well, okay, I see what you're saying. So if you're, when can you stop using birth control?
Yeah.
Right.
Basically.
You can stop worrying when you have had 12 months of no periods and there is not a hormone medication in your system.
That was my question.
So if you're utilizing condoms or a diaphragm, or the male had a vasectomy, the female had a tubal sterilization, she just needs those 12 months.
Okay.
And she shouldn't really trust it sooner than that. Again, if it wasn't tubal ligation vasectomy. So if she's on hormones, we have to have a little chat. They have to come off. They have to pick a different method of contraception. And they still really can't trust it till they have 12 months. But I can blood test her a few months off of the hormones and probably tell her by the blood tests that I'm pretty sure her periods are not going to come back. But I don't want her mad at me that she got pregnant the next month. So I'm going to tell her to protect yourself for 12 months. Yeah, sure. You know, I think I forgot to include that I have. Yeah, okay. So I'm being asked, oh, that's a tough one to reword. What hope is there for enjoyable sex if with menopause we're just going to dry out and shrink? How's that? So I'm realizing I forgot to verbalize, if it was on one of my slides, the role of local estrogen therapy. So local estrogen therapy is a product that we utilize in the vagina to boost back up. I will not get you back to your teens and 20s, but I can probably get you back to the status you were in your 40s, which is supposed to be our peak. So it's, if you are interested, and that's why I wish women would at least learn about it sooner, even if they don't realize or feel like they want it right away, what local vaginal estrogen therapy is. So you use it in the vagina on an ongoing basis to reboost locally those benefits. And they have tailored the products and the doses to minimize these being able to be called systemic. So they're not going to help hot flashes, and they're not going to give much, if any, breast symptoms, and they're probably not going to boost breast cancer. We still have to be cautious if a woman already has had breast cancer to think about whether she should consider another option first, especially if it was an estrogen stimulated breast cancer. But even those women, if they need it for their sex life, their oncologists and their gynecologists usually will approve local vaginal estrogen. So there's tablets, there's creams, there's a soft bendable ring that sits up in the vagina releasing it. And it's, if you are instructed about it and learn about it and are benefiting from it, you can use it forever. So the comment was just made that an over-the-counter product called Remifemin, which is a combination, I believe, of black cohosh and soy, maybe some other of the natural herbal remedies, has even been supported by the gynecologist. I had some quotes from up there, Dr. Northrup, as a potential non-hormone therapy that you might try. Not particularly speaking to that one, but I did go to Sedona, Arizona once, and one of the was it at that conference? I forget. But anyhow, one of my conferences, there was a female doctor who first had been an herbalist, and then she sort of took a very circuitous route to becoming a MD. And so she had all this really great knowledge. And one of the things I got out of her experience and knowledge is that most cultures that really use herbal remedies do not take them regularly. So they don't pick these herbs and live on them every day of their life. They're used in cycles. So I think there's maybe some thought to that when we do, and maybe we should be thinking that a little bit more in some of our prescription medications as well. And sometimes I think we do, not particularly with the topics I was speaking of tonight, unless you want to feel your symptoms come right back. But sort of, how do you get off of them? Nobody asked me that. How do you get off? Well, we are trying to recommend the lowest beneficial dose for the least amount of years. But how do I know that? I don't know that till we work together. So when a woman is on systemic hormone therapy, we are going to probably connect and review it just about every year, year and a half, 2 years. And I often will recommend, not that this is proven, I'll recommend a wean off. And it serves two purposes. Maybe you don't get such a rebound, and you also are kind of seeing where you're at as you're weaning off. And I think the easier it goes, then you might actually go, oh, I think I am done with this. I guess I don't have those strong symptoms anymore. So I'm being asked whether the local estrogen vaginal therapy does benefit bladder function, and it does. I mean, I always like to say I'm not promising a cure-all, that you won't leak when you sneeze hard or have 3 coughs in a row. That's called stress incontinence, which actually needs probably either some physical therapy training, maybe even needs a surgical procedure to help it. But much more women are struggling with urgency and frequency, and that's where that often actually progresses with perimenopause and menopause because of the low estrogen, so that we can help that. And I think the urologists, it's right in their pocket. They're very eager to put women on local vaginal estrogen to help the bladder.
Perimenopause.
In general, most uterine cancer is not at all genetic or familial. We definitely, maybe everybody here knows, we're a little more worried about breast, ovarian, colon, prostate. There is one sort of a familial genetic, I think it's the Lynch, I think. But in general, it's usually not. You could probably just, if you had some pretty good details about your sister, have that conversation, but probably you're safe.
Okay.
Yep. Maybe, I didn't see any other hands, but one more.
The vaginal.
Never too late for that. If you said to me, can I come in 65, 70, and I'm not trying to guess your age there, but if a woman came into me that far after menopause and did tell me she was one of those 9% still having hot flashes, I'm not going to treat her with systemic hormone therapy. It's just too risky. I do help support some women who transfer to my care, who are still on it. I bring their doses down. I get them to try using it less and coming off of it, because I am worried that long-term use of systemic hormones is going to eventually boost up cardiovascular or breast cancer in her, but not the local, so it's never too late. And there are other things too. We can help women with dilators to get vaginal size and capacity back. It's going to work better with that vaginal estrogen product, so it's never too late. Well, I thank you all very much for your kind attention, and hope you learned a little something tonight. Thank you.